Welcome to our video on keloids and hypertrophic scars. Let's get started. So we're going to cover the definition, pathophys, risk factors, the presentation, as well as the diagnosis and management and prevention of keloid scars. Now, keloids are defined as fibrous growths that extend beyond the original area of the injury, and they occur secondary to an excessive response to the dermal injury. And why is there this exaggerated response? Well, it happens because of the overexpression of growth factors. Now, one of the main growth factors involved in the pathophysiology of keloids is transforming growth factor beta. So this TGF beta promotes the differentiation of fibroblasts into myofibroblasts. So these myofibroblasts then produce contractile actin filaments and high levels of collagen. And those two things together leads to contraction of granulation tissue. And that occurs as the scar is forming. Now, other mechanisms that lead to the formation of keloid scars include decreased production of molecules that break down the dermal matrix. For example, a loss of matrix metalloproteinases. And in keloids, there's also increased amounts of platelet-derived growth factors. And there's decreased fibroblast apoptosis. So hopefully you can gather that this idea of keloids really is a product of too much myofibroblast activity, too much collagen, there's contraction, and there's not enough destruction or inhibition of some of those activities. Here's a histological image from a keloid scar. The most characteristic part of this image is the eosinophilic and hyalinized collagen bundles. And notice how the collagen is disorganized, and that disorganization of collagen is very characteristic of keloid scars. So now let's talk risk factors. The main risk factor for keloid scars is Hispanic or African ancestry, and a family history of keloids also leads to an increased risk of the patient developing keloids themselves. It's probably the most intuitive and easy one to remember. If your mom or dad had keloids, then you're more likely to have keloids. Now, both of these risk factors suggest that there may be some genetic predisposition to developing keloid scars. However, there's actually no clear mode of inheritance or any identifiable genes at this point. We just don't know. So it's kind of this broad idea. If you have Hispanic or African ancestry or someone that came before you had it, then you're more likely. But we don't know exactly why. Now, keloid scars present as raised dermal lesions that extend beyond the edge of the wound. Just as we mentioned before, there's just too much of that activity. So naturally, it goes outside the boundaries of what you'd want. Now, these scars can develop even with minor injuries, or even if there's no clear injury at all. And it can occur within a month after the stimulus. And the location on the body that is most vulnerable are the ears, head, neck, upper chest, shoulders, or upper back. So you're really just thinking upper body, shoulders and up, basically. And these scars tend to enlarge over time. They don't just regress on their own. In addition to being just frustrating or unexpected and not liked by the patient themselves, the patient may also complain of pain or pruritus or functional impairment. And when you think of that functional impairment, just think about how large these can truly become. So it actually limits some of the activities that they would expect or want to do. So in this image, there's a large keloid that's evident over the patient's ear. So there's several features of keloids that are evident in this image. So let's break those down. So first, it's large, it's irregular, and it progressed beyond the borders of the original wound. We could kind of guess, but we don't know exactly where the original wound was. But wherever it wasn't in this shape. So this is definitely overgrowth. Second, this is in a location that's very common for keloids, the earlobes. Third, the patient's ethnicity is one that is at a higher risk of developing keloid scars. Remember, Hispanic ancestry and African ancestry. As with many dermatologic pathologies, it's typically diagnosed based on clinical appearance. However, if there's ever uncertainty regarding a lesion, then you can do a biopsy to make sure that it's a keloid. Otherwise, you see it and you determine that it's a keloid. Okay, so now let's say you've diagnosed it. You visualized it and you know that it's a keloid scar. What do you do about it? Okay, so the first thing for you to know is that management of keloids is actually very difficult because there's such a high risk of it coming back. So it's important for providers to discuss that fact with the patient to make sure they have realistic goals, and you want those prior to setting up any treatment, because no matter what you do, there's still that high risk of recurrence. Okay, but if you're going to actually do something about it, so the first line treatment is intralesional corticosteroids. So why do these work? Well, those steroids actually lead to decreased collagen synthesis and decreased fibroblast proliferation, which can in turn soften and flatten the scar. In addition to helping with the appearance of the scar, steroids can also help decrease the pain and the pruritus that are associated with that keloid formation. One thing to keep in mind, however, is that corticosteroids can lead to dermal atrophy and even ulceration of the skin or altered pigmentation of the area where you've injected it. So the bottom line here is that keloids come back. It's not a perfect solution, but you inject steroids, but keep in mind that you can cause some of these skin issues as a consequence of these steroids. Okay, what else can you do? Well, the second line treatment is intralesional 5-fluorouracil, abbreviated 5-FU. So this actually can only be used if there's no response to corticosteroids, which makes sense. It's second line. You try it after you've tried corticosteroids. But why does 5-fluorouracil work? Well, what it does is induce apoptosis of the fibroblasts. And by doing so, it inhibits TGF-beta. So that right there should result in a decreased size of the keloid. Now, 5-FU also has the additional benefits of reducing the pain and the hyperpigmentation associated with the keloid. Okay, now what if those therapies don't work? Can you step it up and do something more severe? Yes, you can attempt that with surgery. So, of course, this is a last resort, and you're going to be doing it in combination with those other therapies. And understand that this surgical treatment has a very high risk of recurrence. So you haven't changed anything there. You went in knowing that keloids have a high likelihood of recurring, and that's even with surgery. And this recurrence with surgery is actually super logical because what caused the keloid in the first place? It was an injury, and it was an overabundance of that fibroblast and collagen formation, and just a dramatic response to it. So if you create a new incision to remove the old response to a previous incision, then it makes sense that it might come back. So high risk of recurrence, but just know that it can be attempted. So now you've got a patient that you know has a propensity to develop keloids. So the goal for you is to actually help them prevent getting additional ones. So there are several steps that you're going to take or help them take to help reduce the risk of developing a keloid. So first, you got to help them keep the areas of skin damage moist. So if they ever get like a cut on their arm, make sure they keep it moist afterwards. Also, they should avoid stretching or putting any tension on the wound. You don't want any stimulus for those fibroblasts to think they've got a lot of work to do. Just remove the tension, keep it moist, and then of course, avoid the sun. So while that wound is healing, avoid sun exposure. Okay, now let's do a question to apply what we've talked about so far. A 27-year-old African-American man comes to the physician due to a large mass on his right earlobe. He got an ear piercing on the right earlobe 1 month ago. 2 weeks ago, he noticed a mass that gradually enlarged beyond the edges of the initial minor wound. And he feels mild pain and pruritus in that same area. Physical exam reveals an irregular mass covering the superior part of the right helix. What's the first-line treatment option for this patient's condition? So this patient has a large mass on his right earlobe after getting a piercing, and then it's gradually enlarged. So it's got this overabundance of collagen and fibroblasts, and this overreaction of those fibroblasts to this initial minor wound. It was just a piercing. So given this man's ethnicity and the description of the skin lesion, it's really consistent with a keloid. And you may remember that you can diagnose a keloid just clinically. And if there's any concern or question, then you can biopsy it, but you can be pretty comfortable that this is a keloid just by looking at it. Okay, what was the first line treatment? Intralesional corticosteroids. And recall that those work because they decrease fibroblast activity and they decrease collagen synthesis. So it helps shrink that scar tissue. Okay, now that we've talked about keloids, let's move on to hypertrophic scars. Hypertrophic scars are fibrous growths secondary to an excessive response to dermal injury that remains in the area of the wound. So far, this kind of sounds like a keloid, but these scars, in contrast to keloids, tend to regress over time. Now, the pathophysiology of hypertrophic scars is similar to that of keloid scars. However, I want to point out a few things that are different, particularly when it comes to histology. So with hypertrophic scars, the collagen fibers are in a wavy pattern, and they're primarily parallel to the skin surface. So this is a little bit more organized than the histology found in keloid scars. As you recall, there is this disorganized pattern associated with keloid scars. Now let's do a question to apply what you've learned. A 46-year-old woman comes to the physician due to a skin lesion on her left thumb. She's a chef, and she accidentally cut her right thumb with a steak knife 1 month ago. She noticed a gradually enlarging mass in the area of the previous cut. The physical exam shows a small longitudinal scar that does not extend beyond the edges of the initial wound. How does this patient's skin lesion differ from that of a keloid? Okay, so this patient cut her thumb with a knife 1 month ago, and now she has a small longitudinal scar in the area of the previous cut, and it doesn't extend beyond that initial wound edge. This presentation is most consistent with a hypertrophic scar. So let's compare this hypertrophic scar to a keloid. So a hypertrophic scar is characterized by collagen fibers, and again, those are in a more organized parallel to the skin formation, whereas keloids are disorganized. Additionally, hypertrophic scars are confined to the borders of the initial wound, and their recurrence is rare, while keloids extend beyond those wound edges, and recurrence is common. Okay, so what are the risk factors for hypertrophic scars? Well, in contrast to keloid scars, hypertrophic scars don't have any genetic predisposition, and there aren't any identified risk factors. Hypertrophic scars can be present at the sites of surgical wounds, lacerations, burns, inflammatory skin conditions, and even infectious skin conditions. And these often appear as raised and erythematous lesions, and they don't extend beyond that original margin of that wound, as we discussed before. And typically, they have this rapid growth phase, and it lasts up to 6 months. And sometimes they can regress over 1 year to a year and a half. Here we see a photo of 2 hypertrophic scars. So these scars most likely are formed over initial lacerations. And notice the fact that the scar tissue has remained within the borders of that original wound. So you can really make out what kind of wound it was. And similar to keloid scars, you diagnose hypertrophic scars just based on its clinical appearance. But if there's any uncertainty, then you can do a biopsy. But that's typically not necessary. But how do you manage these? Well, some hypertrophic scars can spontaneously regress and not require any management. However, sometimes the patient might desire treatment for their hypertrophic scar, and if that's the case, then the first-line option would be silicone gel sheets and pressure therapy. But how do these work? Well, the silicone gel sheet really doesn't have a clear mechanism of action, but they can be used for the treatment and actually can help prevent the formation of a hypertrophic scar. And the use for pressure therapy is to help improve the appearance of the hypertrophic scar. So this can take the form of pressure garments, like something to press against the scar, bandages, or any other device that can keep pressure on the scar. So the idea here is that this pressure leads to reduced oxygen tension in the wound, and that results in decreased fibroblast proliferation and decreased collagen synthesis. So that should in turn decrease the size and how apparent that hypertrophic scar is. Okay, but what's second line? So if silicone gel sheets and pressure therapy do not improve the hypertrophic scar, then you could do something like intralesional corticosteroids, laser therapy, and even surgical excision. So how do you prevent these? Well, it's the same as keloids. So you want to keep the area of the skin moist. So for example, if you get a laceration, keep that area moist, avoid any stretching or tension on that wound, and avoid the sun. So very similar to keloids. Okay, now let's do another question. A 21-year-old man comes to the physician due to a skin lesion on his chest. He underwent cardiothoracic surgery at the age of 3 due to a large ventricular septal defect. He noticed a slowly enlarging mass in the area of the previous wound. The physical exam shows a midline vertical scar confined within the borders of the initial wound. He feels embarrassed by his skin lesion, and he asks about treatment options. What's the first-line treatment for this patient's skin lesion? Okay, so this patient has a midline thoracic scar that appeared due to a surgery that he had when he was 3 years old. And this scar is confined to those same borders of the initial wound. So we know we're dealing with a hypertrophic scar. So what's the first-line treatment? That would be silicone gel sheets or pressure therapy, and both at the same time perhaps. Now here's a table that you can use to help review and summarize the contents of this video so you can compare keloids and hypertrophic scars. And that concludes this section.